Hi guys, hope you and your families are doing safe in these terrible times. Continuing our short discussion series, here's my video number 3. In the previous video, we did discuss some aspects about ABG analysis, and I had purposefully told you that I'm skipping urine anion gap because I'm going to make a video on that. And keeping with the same thread, in this video, we're going to discuss about urine anion gap and its relevance. Okay, so let's go to the MCQ. 24-year-old female is being evaluated for progressive muscle weakness of several months duration. She provides no pertinent personal or family history and takes no medications. Her vital signs are 100/60 BP, pulse rate of 98, respiratory rate of 16 and BMI of 19. Serum electrolytes are sodium 142, potassium 2.8, chloride 120, bicarbonate 15. Yes, we'll notice that. Bicarbonate 15 and potassium 2.8, two values that are really off, and chloride is slightly high. And urine electrolytes are sodium 18, potassium 8 and chloride of 32. Urine analysis shows a pH of 5. There's no blood or protein. What is the cause of this patient's metabolic acidosis is the question. And the options are laxative abuse, surreptitious vomiting, type 1 distal RTA and type 4 distal RTA. So what is a stepwise way of solving this MCQ? Okay, if you remember the last video, we know now that this patient is having metabolic acidosis because that's a question in itself, and we also know that the bicarbonate is low. So whenever there is a metabolic acidosis, our first responsibility is to see whether it is anion gap metabolic acidosis or non-anion gap metabolic acidosis. Okay, so we know the formula. It is sodium minus the addition of chloride and bicarbonate. So let's go for it. So our values are 142 minus the addition of 120 plus 15. Yes, I hope you're clear with that. So that makes it 142 minus 135. That is only 7. Okay, so there is no increased anion gap. So it is a non-anion gap metabolic acidosis. This much we know now. Okay. Going to the next slide, this question is about non-anion gap metabolic acidosis. So what are the causes of non-anion gap metabolic acidosis? Very quickly dividing, you have to know the concept that the body is losing bicarbonate. The body is losing bicarbonate. So that loss of bicarbonate, okay, loss of bicarbonate, that loss can either be extrarenal or it can be a renal loss. Okay, so extrarenal, we'll come to the causes in the next slide, and renal loss. There's one other mechanism by which there can be a non-gap metabolic acidosis. That mechanism is the inability of the kidney to excrete acid. Inability of the kidney to excrete acid. Okay, so this is what is happening in distal RTA. Please remember that. This is what is happening in distal RTA. So two causes, non-anion gap metabolic acidosis. There is an extrarenal loss of bicarbonate or there is a renal loss of bicarbonate. Either that or the kidneys. There is a inability of the renal system to excrete acid, which is what happens in distal renal tubular acidosis. So just going through the tabular column given in Harrison's 20th edition. So you can see that the causes of non-anion gap acidosis is there in chapter 51, this table number 5. There is a gastrointestinal bicarbonate loss that could be either due to diarrhea or an external pancreatic or small bowel drainage like in surgeries, or a connection between the GI system and GU system. Okay, that is a ureterosigmoidostomy, a jejunal loop or an ileal loop, or certain drugs like calcium chloride, magnesium sulfate and cholestyramine, which is a bile acid sequestrant. Or renal acidosis. Okay, in hypokalemia you can have a proximal RTA in which there is a renal loss of bicarbonate. Okay, and certain drugs which can mimic these effects are acetazolamide and topiramate. Please remember that, acetazolamide and topiramate. The other MCQ is topiramate, due to this same reason, has a tendency to crystallize as well. Okay, causing stones. Okay, an anti-epileptic drug that can cause stones. The other drug is zonisamide. Couple of extra MCQ points there. And the other one is a classical distal type of RTA. Here the kidney has an inability to excrete acid. Certain drugs that can cause it is amphotericin B. The most important example that you have to remember is amphotericin B. and ifosfamide, which is a alkylating agent. And in hyperkalemia, you can have your type 4 RTA, okay, which can be caused by mineralocorticoid deficiency, mineralocorticoid resistance, or voltage defect, or in the cases of chronic tubular interstitial nephritis. And normokalemia, that is CKD itself, can cause a non-anion gap metabolic acidosis. We already told you that when the GFR is more than 15, that is in the earlier stages of CKD, you can have a non-anion gap metabolic acidosis. When CKD becomes advanced, you more often than not expect a high anion gap metabolic acidosis. So some other causes are drug-induced hyperkalemia and others. This I'll let you go through in the book itself. So remember chapter number 51, table number 5. Okay. Couple of important points that I want you to note here are trimethoprim and pentamidine. Okay. These interfere with creatininases and can lead to an increased creatinine. Okay. This interferes with the creatinine secretion in the kidney and can lead to increased serum creatinine levels. Okay, so please remember that MCQ point also. So coming to the concept of urine anion gap. So whenever you have a question of a patient with a non-anion gap metabolic acidosis, it's important for you, okay, it's important for you to determine whether this metabolic acidosis is having a renal origin or an extrarenal origin, and for that you have to calculate the urine anion gap. What is the formula to calculate the urine anion gap? It is urine sodium plus urine potassium minus urine chloride. This gives you the urine anion gap, and please remember that whenever the value is positive, okay, whenever the value is positive, it means that the loss of bicarbonate or the metabolic acidosis is due to a renal defect. It's a renal origin. And whenever the urine anion gap is negative, it means that the kidneys are responding appropriately to the systemic acidosis and there is some extra renal loss. Okay. So instead of just mugging up this concept, I'm going to try to impress upon you why this positive negative thing is there. So look at this diagram here, a very simple and a nice diagram which can easily make you understand why this is happening. Now, whenever in the face of systemic acidosis, what the kidney does is to increase more acid, retains bicarbonate and increases acid excretion. Very simple. Whenever there is systemic acidosis, the kidneys respond by excreting more acid. So how does it excrete more acid? Okay, here comes the role of ammonium. Okay, there is more production of ammonia in the kidney, which is excreted in the urine in the form of the ammonium ion, NH4+. Okay, that's the normal response of the kidney. Now, this is not routinely measured and serves as a unmeasured cation. Okay, unmeasured cation. Now, we all know that the number of cations and number of anions in toto are going to be equal. The left hand side is equal to the right hand side, as we say in mathematics. So that's why this box is there. Okay, urine chloride and sodium, potassium and ammonium. So these two have to be equal. Now, whenever the kidney is responding to the systemic acidosis by increasing the amount of ammonium, you expect this box to slightly change in dimensions. Okay. I'm going to quickly tell you that. I'm going to redraw this box here with chloride in the bottom aspect and sodium, chloride, ammonium. So imagine that it's a systemic acidosis now, as in this patient, and then imagine the kidneys are responding. So it's going to increase the secretion of ammonium. Okay. And left hand side is equal to right hand side. So you have sodium, you have potassium, and then you have ammonium. Okay, now it is because of this, okay, this increased excretion of ammonium is reflected in the urine anion gap as a negative value. So now in this, because ammonium is an unmeasured cation, in case the ammonium excretion is increased and the kidneys are responding well to the systemic acidosis, you are going to have a negative value, isn't it? As simple as that. Okay, because this part subtracted by this whole part is obviously going to be a negative value. It means that there is some other unmeasured cation in the urine, and that cation is ammonium. Okay, it's not easy to measure ammonium in the urine, so this is a surrogate way of measuring the ammonium excretion. I hope you're very clear about this concept. That is why whenever the urine anion gap is negative, it is an appropriate response of the kidney in the phase of a systemic acidosis. Whereas if the kidney is the problem, then this ammonium is going to be so less, obviously, and therefore you expect a urine anion gap to be positive. In that scenario, you expect the urine anion gap to be positive. So let us apply this formula in the current question. Again, coming back to the question. So let us use this formula and apply it to our MCQ and try to find out the answer. Okay, so we already discussed that the anion gap in this patient is only 7. So it is a non-anion gap metabolic acidosis because there is a decrease in the serum bicarbonate. Talking about the urine electrolytes, let us calculate the urine anion gap. Okay, so sodium plus potassium minus chloride. Okay, sodium plus potassium minus chloride, that is 26 minus 32. We are getting a negative value of minus 6. This means that this loss of bicarbonate is not having a renal origin. The kidneys are appropriately responding to this metabolic acidosis. That rules out option number C and option number D. Okay, option C and D is eliminated because it cannot be a renal tubular acidosis. If it were a renal tubular acidosis and the kidney is the culprit, you would have had a positive urine anion gap. Okay, so I've noticed that in the Telegram group, maximum number of candidates picked option C, type 1 distal RTA. So that's the wrong answer. Okay, urine anion gap is positive, so it cannot be renal tubular acidosis. It has to be one among option A or one among option B. Now discussing about option B, which is surreptitious vomiting, that is also wrong because in case of vomiting, you are losing acid. The hydrochloric acid in the stomach is getting lost, and therefore vomiting causes a metabolic alkalosis because there is a loss of acid from the body. It does not cause a metabolic acidosis. Please remember that. So the correct answer is laxative abuse. The correct answer is laxative abuse. So you have a hyperchloremic metabolic acidosis, a non-anion gap metabolic acidosis with a negative urine anion gap means that there is an extrarenal loss of bicarbonate which can be explained by the laxative abuse. Talking about the clinical scenario also, you have a young female with a low BMI, not exactly low but not optimal either. So she has a low borderline BMI of only 19, yeah, and 24 years old. Okay, so a lot of body dysmorphism disorders are there, like eating disorders like anorexia nervosa, bulimia. They are all having a tendency to overuse diuretics or laxatives so that they can maintain their body mass index. So even the clinical scenario fits the option of laxative abuse. So the correct answer to this MCQ is laxative abuse. So please remember the concept of urine anion gap and identifying the source of acidosis, whether it is renal or extrarenal. Okay, so thank you, and to help you prepare better for NEET SS nephrology, we have two things. We have the NeuraxisPro app in which I have notes based on 𝗡𝗘𝗃, okay, and 4 grand tests, and also we've uploaded around a handful of videos, 10 to 11 videos already on various topics of nephrology. We'll keep updating the videos and notes, okay, so that we can take you through the length and breadth of nephrology together. We can travel together across the length and breadth of nephrology. And for those who are interested in solving MCQs, we have a 1200 question bank which is also going to be regularly updated, and this is available on the Surgtest app. Okay, both these apps are available both on Android and iStore. Please subscribe to our app and make use of the material and give us your valuable feedback. Thank you. I'll see you in the next video soon.